So, respected leaders, chairpersons, co-speakers, and colleagues, a warm good morning to all. At the outset, first, I would like to take this opportunity to thank Dr. Vijayakumar sir for giving me this opportunity to be a part of this prestigious conference and to speak on drug-induced diabetes, which is a very, very common problem we see day in and day out in our OPDs, as most of our patients come with a lot of comorbidities, so polypharmacy cannot be avoided. So we should know the diabetogenic nature of the drugs that we give to them in order to prevent glucose spikes in our patients. So as we know, many medications are associated with increasing glycemic levels, and any acute insulinopenic severe drug-induced hyperglycemia can be life-threatening. And chronic hyperglycemia can lead to long-term complications like cardiovascular risk. So when use of a specific medication leads to the development of diabetes, we can coin the term as drug-induced diabetes. And if medications which cause glucose control to deteriorate in patients with already having diabetes, then we call it as drug-induced hyperglycemia. So here I have a list of drugs, the most commonly used ones and less commonly used ones. Still drugs are there, they're keeping adding every day. So the most commonly used drugs are the ones I will be discussing today. And going on to the mechanism of action by which it causes diabetes, mainly by beta cell destruction by cytotoxicity, inflammation, or autoimmunity, leading to decreased insulin secretion, decreased insulin synthesis, and also impairing the intracellular signaling, which leads to excessive glucose influx. So there'll be weight gain, hyperlipidemia, and increased peripheral insulin resistance in the muscle, adipose tissue, and liver, leading on to the development of hyperglycemia. So here I have a pictorial representation of the mechanism of drug-induced diabetes based on the medication classes and their site of actions. So as you can see in the pancreas, whether it is the antipsychotics, the statins, beta blockers, or SSAs, or the anti-neoplastic drugs, all of them cause beta cell apoptosis, hence impairs both glucagon and insulin secretion. In the liver, they tend to cause upregulation of gluconeogenesis, so there'll be an increase in the serum glucose values. And the skeletal muscle, it inhibits the action of GLUT4 inhibitors, so there'll be a decrease in the glucose uptake. In the periphery, it causes vasoconstriction, mainly the beta blockers, leading to the decrease in the glucose delivery to the target tissues. In the GI, the blood flora is affected mainly by antibiotics, so there'll be an increase in insulin resistance. Electrolyte, as we know, thiazides cause hypokalemia, and this hypokalemia causes decreased insulin resistance. In the adipose tissue, it causes central obesity, increase in weight gain, and the CNS, it increases the appetite. All of them together cause increase in weight gain and increased resistance. All of this contribute to the development of hyperglycemia. So the risk factors, we can see patients with pre-existing diabetes, the glucose values in the impaired fasting glucose levels or impaired glucose tolerance levels, a family history of diabetes, history of gestational diabetes, higher BMIs, abdominal obesity, higher age group patients are at risk of developing drug-induced diabetes. So starting with steroids, depending on their route of administration, they have the effect on blood sugars. Like highest hyperglycemic risk is with the patients when we give them oral, intramuscular, or intravenous. And moderate risk is with intra-articular injections. That is, they cause short-term spikes. And low to minimal risk is seen with inhaled, topical, nasal, or rectal routes. So how do they cause hyperglycemia? This is mainly by increasing the gluconeogenesis. So insulin sensitivity will immediately go down. And in the pancreas, it increases glucagon, decreases insulin secretion, progress to beta cell failure. In the skeletal muscle, it causes decreased proteolysis, decreased glucose uptake, decreases the muscle mass too. Decreases incretin effect. In the adipose tissue, it causes more of lipolysis, increases appetite. All this contribute to the development of hyperglycemia, ketonemia, and the patient can go in for DKA also. So going on to the treatment approach, whether your patient is a type 1 diabetic or type 2 diabetic. Type 1 diabetics on basal bolus or premix, keep monitoring daily their blood sugars. And if necessary, you can add short-acting insulins. Type 2 diabetic patients, if they are on insulin only basal or premix, adjust the doses, monitor the glycemic levels. If needed, add short-acting insulin. If not on insulin, start with OHAs like glycoside. Start with 40, you can up-titrate till 240 also. If needed, insulin can be added too. So what are the inpatient recommendations? If the patient needs an admission, so check first before starting steroids, check the HbA1c, glucose values. Patient is already a diabetic. Monitor their sugars 4 times a day. Still there is glucocorticoid-induced hyperglycemia, type 1 or type 2. Type 1, if they are on basal bolus insulin, every day monitor their blood sugars, up titrate by 10 to 20%. If needed, you can transfer the basal to the morning also, as postprandial hyperglycemia is common with steroids. Type 2 diabetic patients not on insulin, start with glycoside, as I've already told you. If they are on insulin, up titrate the insulin. If they are on OD, you can make it BD also. But if the patient is not a pre-existing diabetic patient, daily do at least once the blood sugar. And if there is a glucocorticoid-induced diabetes occurs, then start them on OHA first. And if needed, you can add an intermediate acting insulin in the morning too. And also keep tapering these OHAs and insulin as you keep tapering the steroid doses. So even after stopping the steroids, at least till 6 months, you should monitor their blood sugar values. Similarly, in outpatients also, pre-existing diabetes or they do not have diabetes. Pre-existing, ask them to check 4 times and keep monitoring and up-titrating as per the inpatient recommendation I've told you. And if they're not a pre-diabetic, but if they do not have existing diabetes, check for all the risk factors. But if still it goes high, HbA1cs are high, start them on OHS. If needed, you can add insulin. Similar as inpatients, as you taper, keep monitoring the blood sugars. Going on to thiazide diuretics, they mainly cause hypokalemia. This hypokalemia is found to decrease the insulin secretion and insulin resistance by inhibiting the cleavage of proinsulin to insulin, and also blocks the potassium as well as the calcium channels. So there will be a decrease in the insulin secretion. So at every visit, patient on thiazide diuretics, check their sugar levels as well as the potassium levels. If needed, you can switch drugs also. Calcium channel blockers, they block the calcium channels, so there will be decrease in insulin secretion. So with glycemic control, you can continue CCBs if it is necessary for your patient. Beta blockers, the beta-2 receptors are present both in the beta cell as well as the liver. So what do they normally do? They increase the insulin secretion, and in the liver, they increase the hepatic glucose output. So when it gets blocked, patient gains weight, decrease insulin secretion, and also increase in the insulin resistance occurs. So it is better to switch to the other third generation beta blockers like carvedilol or nebivolol, as both of them was found to improve the insulin sensitivity, and they also reduce the peripheral resistance. So nebivolol is also a vasodilator. So since it is a vasodilator, you can use it for these patients. If needed, you switch to the other drugs also. OCPs, the older OCPs had high doses of estrogen and progesterone, which were diabetogenic. But now we have low dose combined OCPs. They are safe, but at every visit, you check their blood sugar also. Diazoxide, it is mainly used for inoperable insulinoma to treat the profound hypoglycemia. It mainly acts by causing hyperpolarization of the beta cell membrane. So the potassium channels are always kept open. So there's an exhaustion of insulin, it will not get secreted. This condition is usually reversible on discontinuation of this drug. Immunosuppressive therapy, mainly cyclosporin and tacrolimus, they both are very, very hypoglycemic. They mainly cause it by causing beta cell apoptosis and decreasing the insulin secretion. They are the main cause of new onset of diabetes after transplantation. So the incidence of this post-transplant diabetes is about more than 46%. It occurs within the first few months of the transplant. But these drugs are very, very important since graft survival is very important. So give a good glycemic control with insulin for these patients. Antiretroviral therapy, it is found to increase 5-fold increase the glucose intolerance in the patients. Protease inhibitors have a high risk, mainly by causing apoptosis of the beta cells, and also impairs the adipocyte function. So these patients will develop central obesity, hypertriglyceridemia, and diabetes. Somatostatin analogs also decrease the insulin secretion. This condition is reversible. Phenytoin, it inhibits ATP production, blocks the CA+ channels. So this condition is also reversible when you withdraw the drug. Antipsychotics, the atypical ones, that's the clonazepam and olanzapine, very, very notorious. They cause hypoglycemia, mainly by affecting the GLUT4 receptors in the skeletal muscle. So peripheral resistance will be affected. These patients will develop hyperglycemia, beta cell dysfunction, apoptosis, and weight gain occurs here mainly because of increase in appetite by acting on the various receptors that I've shown here. So at every visit, these patients, please monitor their glycemic status, add OHAs when needed. If you can change the drugs, also antipsychotic drugs, please do it. Niacin, anti-lipid drug, it reduces peripheral insulin sensitivity because it increases the free fatty acid levels. Streptozocin, mainly used for malignant pancreatic islet cell tumor. It causes hyperglycemia by causing cytolytic injury to the beta cells. Statins, the very, very common drug we use for most of our patients on statins. They cause about 12% increase in the sugar levels. Jupiter trial proves it. And they mainly decrease the insulin secretion and insulin sensitivity by blocking the calcium channels, decreases the ATP synthesis, decreases adiponectin, GLUT4 is blocked. All of them lead to the development of type 2 diabetes. So statins, as we know, we have lipophilic statins and hydrophilic statins. Lipophilic statins are the ones which have a higher risk when compared to hydrophilic statins. But outweighing the risk versus benefit ratio of the cardiovascular benefits of statins, we continue the drug, give good glycemic control with your OHAs or insulin. Anti-neoplastic drugs, whether they are the mTOR inhibitors or the tyrokinase inhibitors, protein kinase A inhibitors, all of them cause beta cell apoptosis, dysregulation, so it will lead to hyperglycemia. Fluoroquinolones, most common is gefloxacin, which causes hyperglycemia within 1 to 2 weeks of starting the drug itself. So it is very, very important, discontinue, use the latest ones. So many drugs I've showed you here, they all cause hyperglycemia or worsen the blood sugar control in our patients. But many of the drugs are reversible. So try the alternate treatments. So, but when you need to prescribe diabetogenic drugs, be very careful, monitor the glycemic control, and prudently use suitable anti-diabetic treatment so that we can mitigate their effects. So prevention is always necessary. Clinician awareness is very important. Identify high-risk patients, monitor their blood glucose levels, use the lowest effective drugs, dose for shortest possible duration. Alter therapy when necessary and possible. Avoid polypharmacy as much as you can. Thank you very much for your patient hearing.